Narcan, naltrexone, naloxone, methadone, Suboxone, benzodiazepines, opioids, opiates, Klonid, blah, blah, blah. Okay. If I'm sitting in this room and I am not a pharmacology person, where should I go to be able to understand the importance of the distinctions between these medical, illegal street drugs, medical therapies? Where's my resource?
Wikipedia.
Actually, I think NIDA has a very good website where they describe the effects of various medications as well as abuse drugs. So personally, that's where I go.
And also, I think SAMHSA, the Substance Abuse and Mental Health Administration, they have a new pocket guide on medication-assisted treatment that's available free of charge to you. Go to samhsa.gov and search like MAT pocket guide or whatever. And actually, for an example, it's a great resource, especially for those of us who this isn't our specialty.
Okay, second question. So from a public health perspective, we talk about primary, secondary, and tertiary prevention. And the way to think about that for people who don't think in this world is tertiary prevention is you have a problem and we are dealing with it in front of us. Secondary prevention is we have every reason to believe from your past behaviors that you will have a behavioral issue in the future. Primary prevention is there's no predictors, but we're trying to help. I think virtually everything we heard today was on the secondary and tertiary prevention side. Do you see anything on the primary prevention side? Is there something we can teach in schools? Is there something we could do a public media campaign on that would help to resolve this problem?
Well, I think in terms of just starting this before it gets out of hand is on the prescriber end. So when patients go into their doctor, I think that's the most important point because that's where, we do know that about 60 to 80% of the medications that are used come from some doctor somewhere in the United States, Canada, or Mexico. So, so it's kind of starting upstream. Second of all, is sort of making sure that the patients understand the risks of the medication through medication guides and appropriate security of the medications. I think a lot of surveys ask, do patients know how many pills are in their oxycodone bottle at any one time? People I don't keep track of that. And so it's very difficult for medication security. And I think if you really wanted to go back in terms of just school-based prevention, which is so difficult now because every state has got standardized tests, and teachers are so pressed to talk about just getting the kids to just pass these standardized tests so they can get to the next grade, that the kids are really losing out on kind of the important health perspectives. And so I think it would be kind of interesting if the media, like cartoon shows, wrapping, using kind of mixed media, Twitter to do a better job of mixing entertainment and education together. Back in the day, there was a very interesting, I don't know if you guys have ever heard of the show Different Strokes, but it was sort of back in the 80s and 90s, and like Nancy Reagan came on Different Strokes, and this was kind of like the first time that there was a crossover between education and prevention and entertainment. And now it seems like when we get presidents and congressmen, when they go on television, they don't do that. It's more about they go on Jimmy Fallon, which is great because they can read mean tweets, but at the same time, it's like we're sort of losing this opportunity to get the message out.
Okay, last question.
I want to respond to that. I think this is really important. And first of all, the first thing I want to say is that effective drug court treatment is primary prevention for the children of drug court participants. We know that if we don't successfully help these parents to enter recovery, that the likelihood that their children will get involved in substances is quite high. And so we know that's true. But more specific to your question is that especially in family dependency courts, we are now looking at focusing on the children of drug court participants directly and implementing some of the evidence-based interventions that we know are out there that look at building on protective factors, helping kids of drug court participants to have school success and to find something that matters to them. So yeah, I think it's a really important question, and we're hoping while it's not directly tied to our mission in the drug court world, we're hoping for more opportunities to really work with children of participants to further reduce the risk of getting in trouble later on. We'd like to put ourselves out of business eventually.
Great. Do you have a comment?
I don't have much to add to that.
Okay. I have a follow-up in the lightning round, and then I'm going to turn it over to the audience, and it's this. We talk in the research world all the time about reaching out to policymakers and telling them, giving them advice about what they should do. Well, here they are, right? So if you wanted to say one thing to them about what they should walk out of here and go do that would make the world a better place around opiate addiction and therapy and intervention and policy in particular, what's your one thing?
Don't go to Time Magazine, the newspaper, and the New York Times to get your information. I think a phone call to an expert is so beneficial, and it's so, I mean, I get called on a weekly basis in terms of being quoted in major newspapers and media, and then I look to see exactly how the story got framed, and it's crazy of how, I mean, it really is, and how it gets twisted around for a specific purpose. And so, you know, pick up the phone, drop an email, and I think you'll find that you'll see people are more than receptive to help you understand this.
I think that we're doing great research. We need to be able to communicate that better to the community that implements that research into treatment, actual treatment, make treatment more available, and just make treatment much more available and bring it up to the standard of the empirically based treatments that we're discovering every day.
And I would say, you know, listen, continue to support smart alternatives to incarceration for men and women who are in the justice system because they're drug addicted. You know, and then not just drug courts. You know, drug courts we have a population we treat, but other interventions, other options within the justice system for treating men and women as opposed to incarceration or as opposed to just putting them on probation and waiting for them to mess up.
So I'm going to answer my own question, just because I haven't had a chance to say anything. I have a microphone in front of me to show you. Which is to say, I would really think about Medicaid as a mechanism. You look at, so there's a new treatment for Hep C called HCV, which a course of therapy is $75,000, and it cures it. Right? It's a cure. It's not a vaccine. It's not an intervention. It's a cure. Only $75,000 is a ridiculous amount. And the problem with Medicaid is that Medicaid doesn't support efficiencies by passing some of those savings back to the people who are implementing it at the state, county, and municipal level. And so I really encourage you to think about, back here too, to really think about ways in which we can use pass-through funding for Medicaid and supplemental SSI and Medicare and all kinds of different federal programs to incentivize more evidence-based practices where the agency that implements it benefits from the efficiencies that they create by doing more evidence-based stuff. I'm done. Questions? Yes?
Hi, I'm Tony Puente from the American Psychological Association. How can we get our policymakers to value the importance of behavioral health in treating this crisis?
I think showing the return on investment from a financial standpoint always gets everyone's attention. And I think that's one of the things that, we've, in the academic world, we've been very terrible in doing. We have these very complicated interventions that cost a lot of money. And you kind of say, well, so what? So what's the importance of this? And so if you can actually say, listen, for every $1 we spend in the classroom on a program that gets kids to teach them how to stress manage can result in a 25% increase in their GPA over their high school career, that's something that speaks volumes. And I don't think we do that very well.
I think we really need to stress the adverse effects of addiction and on society, the cost of society, our economics, and to make that a really high priority for, it's a problem that we actually can address here in the United States through treatment and education.
And I think it's I think it's just important that those of us who have an opportunity to do so, even as we emphasize the important role that medications can play in the treatment of opioid disorders, that we also remember that, especially for certain populations, and the population I serve, drug court populations, that medication alone will never be enough. There needs to be a combination of approaches that include medications, but also psychosocial approaches as well. There's evidence to suggest that, and what drug courts treat as we work with all of our practitioners is how to incorporate successfully psychosocial as well as bio approaches or medicine approaches to help people get into long-term recovery.
Would you say to this audience that you think there's a difference between behavioral issues and medical psychological issues, and that might create a difference in what kind of policies you set up, where instead of you're thinking about the difference between somebody like the Sarnievs who are just seem to have a behavioral disorder versus somebody like the Sandy Hook shooter who seem to have a real psychopathy, and the use of the way in which we deal with the opioids and things like that they self-medicate with.
Well, I think a big thing to realize is that zebras, dogs, and cats don't get ulcers. And the reason why is because they have different ways of dealing with stress. And so stress and mental health and the diseases and the courses are all linked. I mean, we've all heard about the gastric cancer diagnosis. If you can give somebody supportive mental health, their 5-year survival rate increases by like 45%, right? And so I think sometimes we strip away, we don't think about these things as disease, addictions being a chronic and relapsing disorder. We don't treat it under like diabetes and try to prevent it. I think we fragment the mental health and the physical healthcare systems, and I think we need to realize that when you go in and you go to your primary care doc and he starts talking about, well, why does your elbow hurt? They fix the elbow, but they never really ask, well, why did you keep coming to me with an elbow problem? Well, it's because I have this job and never put in stress, and so it's not until the 4th or 5th time that the doc figures out, oh, okay, well maybe there's something occupational that we need to think about. And it's the same thing with mental health. I mean, people come in with colitis and all this sort of interrelated problems, and the doc never says, hey, wait a minute, let me take a step back and think about holistically what's going on in this person's life. And it's very difficult because you have a 5-minute office visit for a doc and all the medications and the notes and all that stuff, and we put so much emphasis on the doctor visit, and we can't put it just on them. And we need to think about other avenues of holistically addressing mental and physical health.
I would add to that, behavior is, it's always, there are lots of elements to it, but it's always, it's brain originates in the brain. And so if the brain is changed as a result of stress or as a result of substance use or whatever, that's where you can see the problem. The issue is in how do you correct that. You can correct that in some cases with medications, but you can also correct it through psychosocial approaches that have been shown to actually change and improve the brain and therefore change behavior. So I think they're all connected.
There's also very good evidence that there's high comorbidity between psychiatric disorders and substance use disorders, as well as medical disorders. And so evidence suggests also that if we can integrate the care for all 3 of those kinds of disorders, that our patients would benefit immensely, and we could really do a lot toward addressing the problem.
Question?
Yeah. Great presentation. Thank you so very much for all the information and insight. One thing I did have a question about is what are experts doing to talk to policymakers about Good Samaritan laws? And I know Dr. Novak, you mentioned the Indiana HIV outbreak. Indiana previously didn't allow needle and syringe exchange programs, and then when that did happen, they allowed it, and whether or not it actually helped or not in that specific case. But generally, I guess my question is, what are your opinions on Good Samaritan laws and how they can prevent opioid overdose, and what are your opinions on people that are proponents of syringe exchange programs to prevent HIV and hepatitis C.
And if somebody would just define what a good Samaritan law is, because I'm not convinced everything is.
Yeah, just so very quickly, so when a person is in an overdose, when they call 911, in the olden days, cops would show up and they just arrest everybody. So a good Samaritan law provides essentially immunity for the person so that when they initiate care, they don't have to worry about, a cop coming in and arresting them. And so, thinking about it in this sort of the Twitter generation, so my response would be sort of an emoji like I heart Good Samaritan laws, because I think, we know that they work, and we know what the break and why they don't work is because there's not good coordination with the law enforcement boots on the ground. So there's a disconnect between the officers who are making the arrest and understanding the law, and a lot of times we're like, well, this guy was kind of a scumbag, and then and then they find these little kind of crooks or little nooks and crannies to sort of get them arrested for something else. Like there was a case where in North Carolina where the person had a bench warrant out for another outstanding miscourt date or something like that, and so the arresting officer said, well, I'm not going to get him for drug use, but I'm going to get him for this other bench warrant, and I think that kind of defeats the purpose. So we look at this Good Samaritan law too narrowly, and we need to kind of say, listen, let's provide a bubble of immunity where we can just focus on the patient, getting this person care, because a lot of times when people overdose, there's cases like Prince where, they're alone and whatnot, but even Prince had like 20 people in his house, so he wasn't really alone. But overdoses often happen with, your drug runner, your drug partner, and people are scared, and they're scared about, seeking care. And the one of the catch-22 is about naloxone now, which is a great drug, and it gets people to, it's the overdose reversal drug, and you give it to them, and they're back in business, but they often fail to seek care and go to the doctor afterward. And so just sort of, we need to think about the emergency room. So there's an ESPER program, so brief interventions. And so, if we can get somebody to overdose, bring that person and the drug partner in together, they're in the emergency room, and then, treat the person that's got the problem that's overdosing, and also realize, hey, there's a person in the waiting room. This is a great opportunity to do something with that person for some sort of brief intervention. And we know that brief interventions do have some effectiveness, and they do have a very strong return on investment. So.
Other questions? And it's been a long day. Let's go ahead.
Yes. As you know, using data to measure outcomes is kind of a core component to recovery. And especially Mr. Walton, you mentioned a lot about evidence-based outcomes. So my question is kind of, how do your associations currently collect and analyze the data you're using for treatment programs, and how are you working to improve those practices?
Well, we rely primarily on the research community, both those that are federally funded, like NIDA or SAMHSA or the Bureau of Justice Assistance, and other federal and even in private researchers to produce data on what effective treatment is, for instance. And then we take that data and then we convert that into curricula, training curricula, technical assistance protocol, in order to get it out to the field. We don't, at least today, talk to me in 5 years, we don't today sponsor any of our own research. We use what's out there that has been well done, and because all isn't well done, that it is well done, and therefore is generalizable and transferable to a broader audience, and we convert that to curricula. We also try and be sure that our constituency, the people, including policymakers and others who trust in ADCP and who rely on us, that they understand and know what's out there. The last thing I'll say is we put together our adult drug court best practice standards, which what that is a completely research-based a set of guidelines for drug courts, and that has been very helpful in helping policymakers, broadly understand what works, and then, where necessary, legislate accordingly.
Of course, NIDA, we run actual clinical trials, so that's really what we're doing is monitoring the effects of our treatments. Another thing that NIDA has done is develop a clinical trials network with the idea that we would not just do research in the universities, the academic settings, but we'd actually be conducting these trials out in regular community treatment programs. And I think what that does is it makes the people who participated in those, or the clinicians, kind of more aware of an empirically based research, what it takes to prove that a medication or a treatment works, and also to pay attention to how patients are doing so that they can adjust treatments, to get optimal outcomes.
You had a question, but I would just like to answer that just in a really short way, which is to say, there's two different ways to think about using data to maximize the cost effectiveness of our interventions. You can innovate or you can scale, right? So HCV is a proven medical therapy. It's just unbelievably expensive and we don't do enough of it because we need to scale it. A lot of the stuff that we've talked about here today, especially on the behavioral and mental health side, is stuff that we need to innovate and test. And we need to do more of that innovation and testing. I would just say that, if you look at behavioral therapy, we're talking about opioids, we're talking about something that is a criminal felony offense. The National Institute of Justice has been funded at less in the last 4 years than NIDA gets each year. And so that doesn't mean you should take money from NIDA, but there are lots of research institutes around it. Please don't, because then she won't come back and do this again. But there are all kinds of federal agencies that do really important research functions that are just we're spending $50 million a year, which is nothing, right, on justice research, and how are we ever going to do anything that scales anything? Yes.
So my name is Ryan Lilly. I'm from the Appalachian area, which I know you guys mentioned as being heavily hit by opioids. I was wondering, what specific piece of legislation are you guys trying to support, or is there any in combating opioid addiction? And what can policymakers do in support, as far as like my congressman, for instance?
Yeah, specifically, the STOP Act is great, and then the acts to reduce or promote the abuse of term formulations. Those are two very tangible pieces of legislation that are floating around, I think, that are very important. I think the other thing for as you work with your congresspeople is not an easy solutions. Like any solution that says, well, we need to pressure the insurance company for reductions. Those are not, like I said, I don't think that those are going to work. But there are, I think, the two pieces that are out there now, like the STOP Act, are great, and support for that, I think, is welcome.
I would just add that, we talked a little bit about primary prevention and juvenile justice delinquency prevention. Reauthorization is out there, and if you talk about primary prevention, that strikes me as, getting kids on a better life course trajectory, on a better pathway that makes them less likely to get into this situation at all. Okay, question? And then I think we'll do two more and then we'll wrap.
Thank you for being here. It's really hard for me to talk about, but in an effort to try to reduce the stigma of what's going on, we can't just talk about how bad addiction is for society. My younger brother overdosed on fentanyl a couple weeks ago, and he looks like just the rest of us. He wears a suit and tie to work, and he's now to work with people who wear suits and ties. Had he been arrested, his second overdose might have been prevented, because it sounds like the drug courts are doing better than our fancy ERs are of getting people into treatment. So I just hope that people can also think about, when we speak to our members, talking about people as human beings as well. And I don't understand addiction. I wish I could. I wish I could just wring my brother's neck and say, don't take one more pill. But I know that's not how it works. So just keep that in mind, that these are also human beings, and we have to treat them as human beings.
It's important.
Can somebody just say 2 words about what fentanyl is and how it compares to opiates? Medicine.
So fentanyl is a medication that's actually used in anesthesia, but it's extremely potent. It's more potent even than heroin. And we are finding not only is fentanyl itself available, but designer drugs are making minor changes in fentanyl and cutting heroin as well as other drugs, and so that the risk of overdose really increases when people take these very potent opioids.
I live in southern Maryland, and we just started to learn recently of a wave of overdoses because people think they're using heroin and fentanyl, and it's so potent they're overdosing.
And the last thing that's interesting about fentanyl is it's typically not picked up on a urine drug screen.
I didn't know that.
Yeah.
So it's not an opioid.
Yeah, but it's the way that the typical, the drug screens that are used in ERs and they're kind of quick, they call them the quick 9 to 5, so they actually pick up. And so it's, and that's why it's often, it's kind of preferred by healthcare professionals because they can do a drug screening and see when that picked up.
So we're going to end up with a call for more research, I think. Shocking, right? Okay, who wants the last word? I haven't had a call from anybody back here. Anybody have a question back here? Yes, sir.
Thanks again for the great discussion, and just wanted to ask about the role of, we spoke a lot about prevention, but on the treatment side of things, the role of providers. Parents, I was especially interested in the interplay between, the provider community and how they can work effectively with the drug court system, and Kenzie as well with the research that's going on right now.
Well, the treatment provider, if I had more time, I'd talk about all the important elements of the drug court. But it isn't a matter if all those things work well. If all those things are right on point, you got a great judge and great contingency management, everything's in place, but if treatment's not there and effective, then nothing works. It's just the whole model is built on effective treatment, so we rely very heavily on providers to deliver effective services, and they do a great job. The challenge is just like elsewhere, there's new information coming. Many providers have existed for a long time, and there's a struggle sometimes to help providers to get up to speed on the latest. At our national conference, we invited the chief medical officer of Hazel and Betty Ford because they were able to describe their transition as they moved from a model that only did one basic thing and then incorporated a range of responses, including medications, and the struggle there. So that's part of what's happening in the treatment provider world in drug courts, is they're doing a great job. But the current challenges require us to do better and to adopt evidence-based practices, and we work with them to give them training and TA and court pressure to do so.
So one of the struggles in addiction treatment is actually getting people screened for their drug problems. People can go to a primary care and never be asked about their drug use, or alcohol use for that matter. And it would be great if we could get primary care physicians and any treatment to screen for that, and then either incorporate treatment as part of their own practice or have a relationship with some community programs where they refer people and continue to follow them so that it's not under the radar constantly, even in a person who's frequently going to the doctor.
Okay, with that, I'll wrap it up. I would ask you if you would be kind enough to fill out the briefing evaluation form. I want to thank you all for coming, for being with us for 90 minutes. I want to thank the panel for doing an absolutely outstanding job.